morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they'll be addressed.
Good morning, everyone. I'm honored to introduce our mentor for today, Dr. Shiba Asim. Dr. Asim is the consultant pediatrician at St. Catherine's General Hospital. She also serves as the assistant clinical professor at McMaster University and is affiliated with the College of Physicians and Surgeons of Ontario. Dr. Asim is also TeleShadowing's Canadian Medical Director, and we would like to thank Dr. Asim for dedicating her time to us. Thank you.
Thank you. Hello, everyone. First, I wanted to say that thank you so much for giving me this opportunity to present here at this platform. Okay, we can start, I think. So you guys already did my introduction. We can move on from that, but just wanted to clarify one thing, that I work mostly as a hospitalist. I don't do community practice. But we will discuss about all these models later on. My journey begins in Pakistan. I did my medical school, MBBS, from Rawalpindi Medical College in 2001. Then I did my pediatric residency from McMaster Children's Hospital, Hamilton, Canada. And currently I'm working mostly as a hospitalist. I work both in the tertiary care center and community hospitals. So I thought that we will start off with what it looks like for the international medical graduates when they come to Canada and they want to apply through the Canadian system. So as we go, I have put in the Canadian medical resources as well. The pathway for the IMGs start with Medical Council of Canada. The website is there. And basically, this organization is the assessment of the physicians. It is not responsible to give out medical licenses. We start off with the medical assessment, and then we pursue medical license pathway. So in order to get assessment, the criteria to qualify for MCC is that we have to have a degree in medicine that is approved by WHO. One of the medical schools that we do our medicine from, it has to be approved by WHO. One thing. Second thing is that MCCQE, Medical Council of Canada qualifying exam 1, it should be completed. Then the third thing is that 12 months of clinical post-grad training should be completed and verified at the same time. So once we fulfill all these criteria, then further assessment process happens. So in order to apply through MCC for Canadian medical pathway, the things that you can do even before entering Canada from your home country are, first, we set up an account that is physicianapply.com. And then through this account, so many things can be done online and so many things can be done while you're still in your home country. You can start the process. That's actually very nice. Then you submit your credentials. This website offers some exam preparation material. Again, it's a good idea to understand the system and understand their expectations. It's always a good idea to go through these exam preparation material. Then you can even do the step 1 of the exam, that is MCCQE1, outside of Canada if you want to. It is offered in about like 500 countries. So that can be done before coming to Canada. Once all of this preliminary requirements are completed, then the other step is only offered in Canada. And this is an OSCE-based exam that is called NAC, National Assessment Exam. You do that, and then we apply for CARMS, that is the Canadian Matching Services. Now, I have put in here practice ready assessment. Those physicians who have done their residency, done their subspecialties and passed their exams in their own countries, and they're practice ready or have been practicing in their countries for years, they can, after passing all these exams, they can choose the pathway of practice ready assessment. And again, everything is available on the website. They tell you all the pathways. They tell you that which pathway is the most suitable for you. Then we come to, once all the exams are completed and passed, then we go to the next pathway, that is your Canadian Residency Matching Services, carms.ca. I just put in one stream of match here, like R1, main residency match, because I thought this is the most appropriate for the audience here. But if you look at the website, there are 3 more streams, but these are more for subspecialties once you have your residency that was completed in Canada. That offers for pediatric subspecialties, then emergency medicine subspecialties, and family medicine subspecialties. But your most common one is this: when you have completed your medical school and 12 months of internship, then you go through this main residency match. It offers 2 iterations. The first iteration is for applications, opens in fall. Once the application process is completed, then the interviews begin in winter, and the match is announced in April. After the match is announced, then the second iteration opens up. That means candidates still have the opportunity to apply in the second iteration, those who could not get matched in the first iteration. In this Canadian Residency Matching Services, you can apply all over Canada, wherever you want. There is absolutely no restriction in that. The only thing is that once you got a residency in a certain province, then you get licensed to practice only in that province, not all over in Canada. This is the difference. So yeah, we can move on to the next one. Okay, so I just thought that I will discuss a little bit of model how we practice as pediatricians in Ontario. As I explained, in Canada, it's very heavily provincial based. Every province model is different. So I did my residency in Hamilton, that is part of Ontario. My license to practice is restricted to Ontario. And this is the model that we have here. If you go through the hospital model, there are 2 types of hospitals. One is academic tertiary care center, and then their academic tertiary care centers have in their catchment area community hospitals. So the community I work in is St. Catherine's General Hospital. And then I still work in my academic center where I did my residency from. Now, the practice model is very different when you compare the 2. In the academic center, you not only have general pediatricians, you have every single subspecialty under the sun for pediatrics available in academic center. We have level 3 NICU, we have pediatric ICU, we have our own pediatric emergency department, all the services, including social services, like every single services are available. So usually it is more appropriate for the complex higher needs kids. And of course, in the catchment area, they serve the population. Versus in the community, it is more general peds based practice. I can give you the example of my hospital that I work in. There we have, in the community, you never have level 3 NICU, and you never have pediatric ICU. You have general pediatric ward, CTU, and labor and delivery, and level 2 NICU. Then we do not have the subspecialists. And if any kid end up getting sicker, then we always transfer them out to an academic center. We are always limited in our resources. We are very equipped to manage up to a certain level of medical care. But once we have to escalate the management, and every hospital has their different criteria that when they have to notify the academic center and transfer them out. But it is just to give you an example that we have these two very different models here when it comes to the hospital. The second one is the community office-based practice. In the community office-based practice also, we have two types of models. And it is entirely up to the pediatricians how they want to customize their practice. We have primary care practice and we have consultant-based practice. Consultant-based practice obviously is they do not offer the primary care. They only see kids with higher needs, or whenever they get referrals or consults from the community, family doctors, or anywhere else. So these are the two models that we, from the hospital-based and from clinical-based practice that we have here in Ontario. Moving on to the next one. Okay, so the one thing I wanted to discuss today is that what makes pediatrics unique, or as I like to call it, what makes us different from grown-up medicine. There are huge differences between pediatric medicine and adult medicine. So I thought that we can reflect on that and then make our way towards common issues that we deal with in hospitals and in the community. So if we can move on to the next one. So just to give you an idea that whenever we are doing the assessment of the kids, whenever we are taking the history, if you look at this, just look at, focus at the perinatal history. Even in the perinatal history, there are so many questions added here, right? We, as pediatricians, go into all those details about mother health, pregnancy details, her serology, and everything that was significant during the pregnancy, all the details around the birth history, and then the postnatal course that the baby had. Past medical history is basically a few things are common, but few things. Immunizations, extremely important that we go into the details of immunizations, then allergies. Moving on to the next one. Then the developmental history. One of the very extremely important key points in pediatric history is the developmental history. We always ask about extreme detailed history on the development. That includes, and we divide it into gross motor, fine motor, social skills, language, vision, and hearing. And there are certain parameters that we follow. And we have screening questions that we ask at certain ages. And those screening questions or those templates have to be filled out at certain visits. These includes the regular visits at 2 months, 4 months, 6 months, 9 months, 12 months, 15 months, and 18 months. And those developmental screening questionnaires are filled out around that. And the idea behind that is, if there is any delay in any aspect of development, these are caught sooner and the management is started sooner. For the family history, important thing to point out here is that we always get 3-generation family history, ask about consanguinity, and then asthma, allergies, eczema. This is a bread and butter in the community. Social history, again, very important, asking about all those details, school attendance, behavioral history, like all of that comes in that. Going on to the next slide. And then for the teenagers, the heads interview is very important. I forgot to mention one thing, that we In pediatrics, we follow kids from 0 to 18 years of age. So teenage kids usually fall in the domain of pediatrics, and they have their own unique set of presentations. Based on that, this heads interview was set up, basically to get to know them better in their home environment, how they're doing, or school environment, how they're doing, their personal health, assessing and screening for if they have any high risk behaviors, all of those things. Now, physical exam. Physical exam is a very tricky part of our assessment, depending on the developmental level of the kids. If, for example, if it's a baby and crying, then you already know that it can be a very challenging exam. So in peds, we always do an opportunistic exam rather than a head-to-toe, properly organized exam. And a lot of the things that we add to our physical exam is the observations that we have done during the interview. Rest of the points I'm not going to go through. This is very self-explanatory. We can move on to the next one. So this is another thing I wanted to add this slide here to mention and to emphasize my point further, that how different pediatrics can be. That just doing a physical exam, imagine how many things we have to keep in mind regarding the vital signs. If you compare it to a 21-year-old or a 35-year-old, the vitals will be the same when it comes to the standard vital signs. And now here, look at the difference in the vital signs. We have a newborn, less than 1 week, different vital signs for their normal range of vitals. Then less than 1 month has different set of normal target vitals. And if you compare it to more than 12 years old, an adolescent, look at the huge difference in the normal vital sign criteria between an adolescent and a newborn. If a newborn is breathing at a rate of 30 to 60 breaths per minute, for me, it's a normal newborn. And if an 13-year-old is breathing at this rate, it is a significant respiratory distress sign, and I have to admit that kid, right? So in pediatrics, we are literally, every single patient is unique for us. What is their developmental level, and how we have to do their exam, how we have to assess them, and what is the impression we are going to come up with. Like, every single patient is different in that perspective. Moving on to the next slide. Okay, next I thought that we will, so we are in a winter season right now. I thought that we will discuss two topics. One, from the hospital perspective, the most common issues or the medical illness that we are dealing with right now in the hospitals. And the second topic that is coming up will be one of the common consults that we get working in the community offices. Between fall and winter, when the school starts, our hospitals, they literally start to get close to 85% of the pediatric patients that have respiratory issues or respiratory problems. And the top three most common causes are bronchiolitis, asthma exacerbation, and croup. There are so many others, but depending on the season, these are the top three. During the COVID time, those 2 years, because we were extremely lucky that pediatric population was not hit as hard, we had minimum number of cases coming through the hospitals and being admitted. And though after those 2 years, now this winter, we are back to normal. Every single hospital in Ontario is literally in surge. And over our census, the community hospitals and academic centers, they're all full of all these respiratory cases now. Whenever we are assessing a kid with respiratory distress, the common points to note here are: what is their level of consciousness? Again, vital signs are very important. This is the reason I put up the examples for the vital signs earlier on, that tachypnea or pressure, everything extremely based on the age of the patient. It can be normal at a certain age. It can be a sign of respiratory distress at a certain age. So we should be able to differentiate among all the cases. Going through the checklist for the respiratory distress signs: level of consciousness, tachypnea, audible wheeze, accessory muscle use. And when we say accessory muscle use, that includes nasal flaring, retractions, seesaw breathing, we call it abdominal breathing, then substernal, intercostal indrawing. So all of those accessory muscle use, signs of cyanosis, especially central cyanosis. And then chest auscultation almost comes at the end. One of the tip, before we even touch the patient, we always observe first. And if you notice here, with the observation, we actually identified 5 of the signs of respiratory distress, if they're present or not. And then the 6th point is the auscultation of the kid. Moving on to the next one. Okay. So rather than going through every single topic, I thought that I'll just put up the slide here and then we will just go through the differentials. So we divide the respiratory distress, respiratory cases into upper airway and the lower airway. Upper airway presentation is very classical as a stridor, like an inspiratory stridor. And very tip is they usually have normal oxygen sats, because issue is not at the lungs level, it is at the upper airway level. In kids, upper airway is slightly narrow to begin with. And that's why with any viral illness, when the upper airway gets affected and this inflammation, then they are at a higher risk of developing stridor or signs of respiratory distress. It's almost, and with the stridor, especially with certain diagnostic criteria, they're at a very high risk of closing their airway. So it's like a medical emergency. Common differential diagnoses for these ones are croup, foreign body, tracheomalacia, vocal cord lesions, epiglottitis. Now going through the details, croup, as I mentioned earlier also, is one of the most common ones. It is, of course, a viral infection that has settled down in your upper airways. That's all what it means. One of the common ones are influenza and parainfluenza, but any respiratory virus can cause that. The other ones we don't see as much, but especially when the kid has like laryngomalacia, tracheomalacia, on top of that they develop croup, they are at very high risk of getting sicker faster than any other kids. The others are extremely uncommon. Whenever there is an upper airway issue, kids classically presenting with upper airway disease, then the main line of treatment for them is epinephrine in a nebulized form. And we give oral steroid. And usually in croup, upper airway inflammatory diseases, we use dexamethasone that is highly potent and extremely effective. It is a very strong anti-inflammatory. The only thing is it has a little bit of a late onset of action. So during the time it is starting to have its effect, we need to stabilize the kid and we use epinephrine nebulizations. whenever we have a mild croup kid and they respond, we observe them in the emergency department and we don't have to do epinephrine nebulization, we just do DEX, then we don't have to admit them, they go home. But whenever we end up doing epinephrine because we have stridor at rest and other associated respiratory distress signs and symptoms, then we always end up admitting them and observe them. So this is one of the very common upper airway inflammatory disease that we see in the hospitals. And we are seeing that a lot these days. Some common points about the croup, we always tell the parents there is a happen again, happen during the same season, or it may happen the next season. The kids who have a recurrent croup history, we always give them a prescription for DEX so that as soon as the symptoms start, they give their kids DEX and they avoid either a visit to the emergency department or hospitalizations, right? So this is one of the most common upper airway diseases that we deal with in the community during winter. Then in the lower airway means now the disease is happening at the lungs level. If it's an infectious cause, it is almost always viral in kids. And the same viruses, respiratory winter viruses that can cause the symptoms in the lungs as well. Now, the thing that differentiates us between airway and lower airway is the presentation for the lower airway is different. You can easily differentiate the two. In lower airway, usually they present with varying degrees of the respiratory distress symptoms, but then the V's is the one that differentiates them when it comes to the presentation. Usually they can have expiratory V's, but when they are very sick, they can have biphasic V's. They can have either normal saturations or low saturations. The top three here are bronchiolitis, asthma, pneumonia, foreign body, again, not very common, but in kids, especially based on their developmental level, it is always in a differential. And there can be certain cardiac conditions that can cause V's. Again, I'm not going to go into that detail because it is highly uncommon. The common ones are bronchiolitis. How you can explain it? In simple words, it is literally viral bronchopneumonia. It's bilateral lower lung airspace disease. That's it. And asthma, again, self-explanatory. Now, the treatment for these can be different. So it's very important, especially the challenging part here is how we differentiate between bronchiolitis and asthma, because they can literally present the same. So the things that can help us differentiate is the family history and the patient's previous history. If this is an atopic kid, atopic kids means that if they have a history of eczema and allergies, even if they're coming in with the first episode of these, you go into the family history. If there is a strong family history of atopy, parents with a history of asthma or V's or puffer use, then you're thinking more on the lines of, and if it's an older child, right? Like more than 2 years old, 3 or 4 years, then you're thinking more on the lines of that, let's try asthma management first. Bronchiolitis is, of course, viral LRTI, low respiratory tract infection. In this, you will have URTI, upper respiratory tract infection signs and symptoms as well. Like you can have significant rhinorrhea, you can have bilateral conjunctivitis, fever, and in the auscultation of the lungs, you can have significant crackles. Yes, these at the same time. So when you have and kids usually less than 2 years of age, those kids qualify more for management of bronchiolitis first. And that management is mainly epinephrine. You can use epinephrine nebs or you can use epinephrine puffers. Just to mention, one of the most common trigger for asthma exacerbation is viral infection. So that's why I was saying that we can have a bit of a dilemma in differentiating the two, because asthma can also start with URTI, fever, and rhinorrhea and all that, but now you have a kid who is most likely in asthma, not bronchiolitis. So it's always a trial thing. If with the history and assessment, you're convinced it's going more towards asthma, you try the asthma management first. If they don't respond, then we switch to epinephrine. If we are quite convinced that it's bronchiolitis, then we start off with the epinephrine management. But the mainstay of the treatment after that is we admit them, of course, especially if they come in with the respiratory distress signs. We always admit them, fluids, hydration, oxygen as it's needed, and we go from there. Okay, so this is what we are dealing with in the hospitals right now. We start to get very busy in fall, especially 2 weeks after the school opens up. Like, it gets really, really busy throughout the winter. And then till April or the beginning of May, we see this surge, and then things start to settle down. This does not mean that we do not get those viral illnesses or asthma exacerbation or croup or any such thing that is mentioned here during the summer season. We absolutely do. There is always a certain virus going around that can cause all these problems, but the majority of these cases we see fall and winter. Okay, moving on to the next one. Okay, so then I wanted to touch base on behavioral problems. This is one of our most common consult that we get from the primary care providers to assess the kids for behavior. The other common that we get is to assess from developmental perspective. Any issues regarding development, developmental delay, expressive language delay, autism, and all that. Again, it was a huge topic on its own, so I thought I will just touch base on one of the topics that is manageable here today. Going through the behavioral problems, you can divide it in basically two. One is your benign, non-compliant kid who can throw some temper tantrums and can have, some mild aggressive behaviors. But these are very transient behaviors. Usually you see them in preschoolers, and usually over time they outgrow that. Again, as long as there is family support present, they usually outgrow that. Versus we have disruptive behaviors. If you look at the incidence, that is quite high. Like between 9 to 15% of the school-age children, they present with disruptive behaviors. Now, what does define a disruptive behavior, and how we differentiate a disruptive behavior, how we say this is a disruptive behavior we are dealing with, or this is a simple tantrum that we are dealing with. So this behavior is so significant that it is affecting not only the child's quality of life, not only child's ADLs, but also the whole family and wherever they go, meaning, and one of the important places is school, right? It's affecting their school life, it's affecting their family life, the family as a whole gets affected, and of course, child has a poor quality of life to begin with. Now, these disruptive behaviors are the beginning of what I've mentioned in my slide here. That's why it's very important that we diagnose these kids as soon as possible and put them in the counseling or put them through the management stream, so that we avoid all the mental health issues or other concerns that can rise up down the road. And the common ones here are, I would say the most common is attention deficit hyperactivity disorder, ADHD, and cognitive language learning issues. Then the other ones that we see are oppositional defiant disorder, conduct disorder, anxiety and mood disorders. So I honestly cannot stress that enough, that how important it is that we pick up those cases and assess them properly and then put them through a proper stream of management. Really important, because it not only affects the child, but it affects the whole family. And obviously, the child down the road can have significant issues. They can have significant poor academic skills, learning disabilities, physical and mental health, poor physical and mental health outcomes. Now, the few following slides that you guys are going to see, I just wanted to mention that I took that from the Canadian Pediatrics Society website, and I will go over all the pediatric resources that we use here that are extremely helpful and resourceful. So if we can move on to the next one. Okay, once again, it is looking a little bit complex, so I'm just going to try to simplify it. We initially, as I was mentioning earlier, it's very important for us to know that it is kids, like imagine a 2-year-old to a 5-year-old kid. If they don't have, they almost always have, some type of hyperactive behavior, or they can be aggressive, they can throw tantrums. That's up to a certain extent is normal. As physicians, it's very important for us to recognize that up till what point it's benign and after what point we need to start to get worried about it. So that's why we have some identifying factors here. Like I'm just gonna, again, not going through every single thing word by word, but just focus on this in the identifying disruptive behaviors. The first one, like look at just this example, that if you look at the dimension of non-compliance, a normative misbehavior will be, and the kid will just say, no, I am not going to do that. Whereas a problematic behavior will be that if they are not only refusing, but they are not, like whatever they're asked to do, of course, for example, mom is asking to hold my hand, they are refusing that, they are not holding the hand, and if anything, they basically run away. So this is more of a problematic behavior, right? So we need to differentiate between the two, because kids are kids. They can have some flavor of something that falls in the normal domain as well. Now, the other things when we are taking the history that are extremely important to keep an eye on is, when we are assessing, we assess at different levels. We assess at the child level, then we assess the whole family, then we look at the whole environment also. So every single thing counts, every factor counts here. Personal factors, family factors, and what are the environmental factors. Okay. Moving on to the next. Again, this is a very complex slide. I just wanted to mention here and point out that once we have done our assessment and we move on to the screening tools, there are many screening tools available, but I thought I will keep it very, very simple. That's why I took the resource from Canadian Pediatrics Society, because it summarizes everything really well, including the screening tools that are available out there. And one of them is the Child Behavior Checklist. It does tell you at what age they qualify for the screen, and you can tell that you can screen a kid at a very young age, right? Between 1.5 years to 5 years of age. A lot of the screening tools, unfortunately, have a cost to it. Some of the screening tools, families, they don't have to pay for. Okay, moving on to the next. This is something I wanted to emphasize. When we have a diagnosis, when we have a kid with disruptive behaviors, you're not just treating the child, you're treating the whole family, managing the whole family. And it's an extremely delicate situation. Right from the beginning, right from starting to assessing the patient and the family, it's very important that as physicians, we develop a really good rapport with the whole family. trusting relationship between the physician and their families is very important, because what I've learned over time is dealing with medical issues may be a bit easier as compared to with these delicate situations. Developing your trusting relationship with the families is very important. And once you have developed that, I think you have already treated them halfway through, because then they trust you. And with all the management plan that you're going to discuss with them later on, they will be compliant with it. We can come up with all the fancy, diagnostic tools, the screening tools, the assessment criteria, and the management plans. But the most important thing is that if we have developed that relationship with the families enough that they will be compliant, they will go through with that process. And at the end of the day, if as physicians, us and as parents, them of the kid, we are all together able to make a difference in the child's life. Behavioral issues or developmental issues, autism, all of that, these are very delicate topics. So we always take extreme precautions and deal with these situations very delicately. As you can see in this slide, when you go through the management part of it, there are no medications here because there shouldn't be, initially especially. It's more of a how you are going to implement it's basically the group therapy or group treating, sorry, I shouldn't say therapy, group or the parent training programs. And again, I don't want to go into every single detail of that, just to give you an idea, through these training programs, the parents are prepared how to deal with the challenging situations. And the take-home point from this slide will be always stay positive. Positive, positive, positive. You always start with positive reinforcement and then you go with the negative reinforcement. Always hug your child first, whatever they have done, and then you start talking about the consequences. Extremely important. Never start with negativism, never start directly with accusing or criticism and all that. And communication, extremely important. Communicating all the times with the kids. Stay involved with the life of the child, at home, at school, getting reports regularly from the teacher, and then regular visits with your physician, regularly visiting those, regularly after signing up with these programs, regularly attending those sessions, very important. Usually, we do not do medications. If the child has significant disruptive behaviors and has included in that physical, they are getting physical hitting and hurting, then we may start something for them to take at night, but we try our best to stay away from the medical therapy. Okay, now moving on to the next. So on this website, I just mentioned some of the very helpful pediatric resources, just going through them individually. Canadian Pediatric Society obviously is the one that we always follow. We are all members of it. There are very, very good resources available on this website, including some statements. And for the disruptive behavior statement, I actually took it from CPS website. If we can't find a topic on CPS or we want to broaden up the our study, then we go to AAP, American Academy of Pediatrics. The local websites, the local resources that I like to use, one of them is Hospital for Sick Children. Then University of Alberta and University of Calgary has on their website some interactive pediatric cases that I find very, very useful, especially at a medical student learner level. And then there is a pedscases.com. Once again, if you visit that website, it's really informative for the pediatric cases. Okay, and that's it.
Thank you for your kind mentorship and teaching, Dr. Asim. I really appreciate the kind advice and resources. I know I learned a lot personally. If anyone has any questions, they can feel free to ask now, and we will now begin our Q&A session.
Thank you, Dr. Asim. The first question is, what are some unique aspects about your career as a pediatrician, and what is your favorite aspect about this field?
Can you repeat the first part of your question?
What are some unique aspects about your career as a pediatrician?
Yes. So, a very good question. I always wanted to be a pediatrician. Always. There was no question. I didn't want to do anything else. And alhamdulillah, I'm one of the lucky ones who actually got into the pediatric residency program. I think in order to select what you want to do, you have to fall in love with it first. And I literally love what I do. The challenging aspect of pediatrics, I love that the most. Like, as I mentioned, that at every single age group, we have our certain set of challenges, how we are going to assess the patient, and coming up with a management plan. And the other thing that I find is different in pediatrics is you're not just dealing with the kid, you're dealing with the whole family. And what we say in our layman term is, you're not just managing a kid, you're managing the whole family. So this is something that I like the most, the challenging part of it. And working in the hospital, I literally like the thrill of it, especially in the community. As I mentioned, that we have a very different model between community and academic center. And in academic center, you have literally all the help available, and it is literally just one button away. But in community, as a general pediatrician, you are all by yourself. And we have had to deal with so many issues. I have even resuscitated a 27-weeker and dealt with the persistent pulmonary hypertension situations, and a kid coming in with intracranial bleed and seizures and loss of consciousness, like all those. So I like the thrill of it. I think that's the reason that I'm still working as a hospitalist. And this is basically the part that I love the most about it, the thrill of working in the hospital.
Thank you. Our next question is, what is your day-to-day life as a clinical professor? Yeah. And what are your teaching hours like?
Yeah. So basically, so this is basically specific to the working in an academic center, right? The structure for the academic center is that when I start my day over there, I start with the teaching session between 8 to 9 to the learners. And those learners are pediatric residents, senior peds and the junior peds. And then we have medical learners, medical students, we have clerks, we have physician assistants. We start off with the teaching session with them. Then, and the topic is usually pre-selected. We go over one of the pediatric topics that usually based on what the learners want. Then we have then we always, in academic center, we always do bedside rounds. And they are sort of teaching rounds. As we go through one case after another, after the presentation, we go through the whole topic regarding the diagnosis, what the patient has, and we literally basically cover the whole topic. After those teaching rounds are done, then in the afternoon, we have another teaching session that is usually subspecialty based, like, for example, pediatric ID or pediatric neuro, pediatric GI, something like this. So in academic centers, we are involved in a lot of teaching. This is usually how a day looks like in the academic center.
Thank you. Our next question is, what is the reason behind why different age ranges age ranges exhibit different vital signs?
It's an excellent question. Because it has to do with physiology, a slightly different physiology at every different age group. It has to do, like, for example, after the baby is born, I can, starting off with the baby. After the baby is born, in utero, the lungs were not breathing at all. They were breathing through the placenta, the baby. Lungs were completely full of fluid. During the process of birthing, and when they're crying, the lungs take, of course, the dominant part, start taking the dominant part in breathing. In utero, right side of the heart was dominant. And after birth of the baby, significant transition happens. And over time, the left side of the heart starts to become more dominant. With all these significant physiological changes that are happening, this is how the body responds. In the respiratory system, in the cardiovascular system, the heart rate is so high. It's like up to 165 is a normal heart rate, and up to 65 is the normal respiratory rate. Why? Because now the baby's body is adapting to the outside environment. And this is how initially they start. And these vitals, they start to settle between 0 to 7 days of life. So this is all the physiological changes, significant physiological changes that are happening in the body, and all the systems that are over time maturing. Based on that, this is the reaction of the body.
Thank you. Our next question is, what is the most common cause for respiratory distress in newborns?
Very good question. The most common cause for respiratory distress, it's very age dependent. If it's a premature baby, it's respiratory distress syndrome because of the surfactant deficiency. And premature babies, we include up till late prem. Late prem means 35, 36 weekers are also included in that. Then it's very age dependent, and it's very dependent on what were the factors present around the delivery. So age, we already talked about prematurity, RDS, surfactant deficiency. Then coming close to the term, meconium is one of the very important risk factors. If meconium is present at birth and babies they have developed signs of respiratory distress, it can be because of the meconium aspiration. But at term and afterwards, the most common cause is TTN, transient tachypnea of the newborn. And what that is, that means there is still some amniotic fluid, still some fluid left in the lungs, and babies, they breathe fast, they get tachypnea just to try to clear off all that fluid that is in the lungs by themselves. So that's why they develop some signs of respiratory distress, they develop tachypnea. So TTN at term and afterwards is the most common, but meconium aspiration is one of the very significant ones also in your differential. There can be so many other causes too, but the other common ones are pneumothorax that we also always keep in mind. Then there can be sepsis, very important. Always keep in your radar that if it is sepsis, these are the common ones.
Thank you. And approximately, what is the estimate for the percentage of pediatric patients exhibiting viral infections becoming a bacterial superinfection?
Very good question. Yes. What is the estimate? Okay. So one thing I think I did mention briefly, one thing in pediatrics, especially in preschoolers, when they're for the first 3 days of illness, whenever they're coming in with the fever, there is more than 90% chance it's a viral infection. So for the first 3 days, we don't get excited or jump on and start the antibiotics right away, unless your assessment tells you otherwise. This is how the natural course of the disease goes. If they have fevers beyond 4 to 5 days of life, and now the nature of the fever has changed, it's now becoming high-grade fevers, more persistent. And rather than improving, child looks like they're not improving at all. If anything, they're getting worse. Then we always look for if there is any bacterial infection. 3 common bacterial infections that we always make sure that we have ruled out when it comes to that point, and the kids, they fulfill the criteria. are acute otitis media, pneumonia, and urinary tract infection. Now, what are the risks of having those secondary bacterial infection? I would say the risk is at least 30 to 40%. This is again very high on our radar. And out of all these three, the two most common ones are bacterial pneumonia and acute otitis media. Having said that, there can be so many other bacterial infections that you should keep in mind, like sepsis and some intra-abdominal abscess or anything, or osteoarthritis and all that too. But these are the top three secondary bacterial infections that we make sure that we always rule out if they fulfill the criteria, and close to 30-40%.
Thank you, Dr. Asim. Our next question is, how would you differentiate Kawasaki disease from MIS-C in COVID in children?
It is an excellent question. So there are significant overlapping symptoms between the two. Honestly, when the diagnostic criteria for MISC came out, it was so similar to Kawasaki disease. The one very important differentiating factor here is in Kawasaki disease. So first of all, let's talk about the overlapping symptoms that we have. Fever, characteristic quality of the fever for 5 days and so, and the other things that we look for the fever, bilateral conjunctivitis, cervical lymphadenitis, typical type of a rash, and certain types of itises that we see in Kawasaki disease and the MISC both. There are not a lot of things that differentiate between the two, but in MISC, what we have seen is usually their COVID test comes back positive, but then I especially personally have seen 2 MISC cases where COVID test was also negative, but they were classical MISC, and we treated those lines and the patient recovered. The other important thing is the GI symptoms. We are seeing a lot of GI presentations in the kids with MISC, versus in Kawasaki disease, we do not. So these are the two, not that helpful, but these are the two main differences that we see between the two, but they are extremely similar.
Thank you. Which pediatric age group have you seen with the most COVID positive cases, and how has COVID-19 affected children in Ontario?
So age group, I wouldn't say that there was any certain age group. I have seen COVID positive in a 6-week-old, even in a 3-week-old. We had a 3-week-old and a 6-week-old up to like a 17, 18-year-old. Up till now, like we have seen cases in all these age groups, and how it has affected. Oh yeah, so yes, it did affect pediatric population in Ontario, but not enough. As I said, that during COVID, we had in the community hospital, we had like up to 4 to 5 maximum. We went up to six kids in our hospital, whereas my hospital is like 16 bed. And right now we are always in surge. We have more than 16 patients every day. So this was the difference. With the COVID, we had minimum number of patients. We were very, very lucky. And same thing in the academic centers. The presentation of the cases was quite low. And it was absolutely not even close to what we saw in adults.
Thank you. How are congenital heart defects usually treated, given how sensitive it is in newborns at birth?
So it is a very broad question. It completely, entirely depends on what is the diagnosis. The congenital heart diseases, we divide it into cyanotic heart diseases and acyanotic heart diseases. Cyanotic heart diseases are the ones that present almost immediately after birth, and you need to start treatment like ASAP on them. Stabilize them, start treatment ASAP, and transfer to tertiary care center without even thinking twice. Where versus this acyanotic congenital heart diseases, they usually present a little bit late, and most of them, they present quite late, but you know what, let's go over the most common congenital heart disease. That will be much easier for me to say, because literally you can write a book on congenital heart diseases. It is such a broad topic. So out of all the congenital heart diseases, the most common one is ventricular septal defect. And it is a acyanotic congenital heart disease. What does that mean? That the child, baby, after being born, is not dependent on oxygen for life, to survive. It's not dependent on oxygen to survive. It is, we know it's a small hole in the ventricles. It has its own categorization and all. Again, I'm not going to go into those details, but just to give you an idea that how different it can be, like based on the diagnosis, you cannot say that this is the treatment for congenital heart disease and then you're done. No, you have to have a proper diagnosis, and then based on that, you do the treatment. Ventricular septal defect is one of the most common one. About 70% of the congenital heart diseases is ventricular septal defect. It is that common. And even VSD, about 70% of those are conservative management. You just follow in the community over time and then they close. About 30% or even less, they end up needing cardiac follow-up, referral to pediatric cardiology, or surgical management down the road. So having said that, ventricular septal defect, the management, if it's needed, is surgical, not medication or anything. Otherwise, it's you have to tell me the diagnosis and then I can go over the treatment, because it's so many diseases come under congenital heart disease, right?
Thank you. And our next question is, what is the most common gastrointestinal infection in the pediatric population?
Yeah. So it's most common gastroenteritis. It's basically what we call it stomach flu, viral gastroenteritis. So in pediatrics, as I said, especially in a preschooler, always think of a viral infection first before thinking of bacterial, especially if it's the early part of the disease. It's not later down the later part of the disease. And viral gastroenteritis is one of those. It's extremely common. We see that more in starting spring, and the peak is in summer. This is the most common gastrointestinal disease that we see. It's infectious, it's viral. And so treatment is usually supportive. The guidelines are that if we are clinically, after doing the assessment, if we are certain that this is viral gastroenteritis, you don't even need to do the stool sampling or anything. We just go by our clinical assessment and supportive management.
Thank you, Dr. Asim. I'll now pass it off to Manahil to finish our Q&A.
Hi, Dr. Asim. Really quickly about me, my name is Manahil. I'm a University of Maryland student, and I'm studying neurobiology and physiology. So my questions are mainly about the healthcare systems, how they compare to the social determinants of health, etc. So my first question is, the United States system is primarily run by private insurances, and patients pay out of their pocket for their healthcare insurances. So what is the health insurance model like in Canada?
Yes, a very good question. So our basic, we are completely different model than US, entirely different model. You can compare our model to England. Our healthcare is covered by OHIP. I honestly don't even know what it stands for, but it's basically covered by OHIP. So we do not have to pay out of pocket, but it's the basic health. We still are the basic medicine, like the family medicine visits and subspecialists and all of that, is all completely, entirely covered. We never have to pay out of pocket. Going through the general peds, primary care, like for example, primary care practice, and parents ask all these questions all the time. What if immunizations are covered or not? So all the visits with their primary care provider, including the vaccinations, including the antibiotic prescriptions, all the treatments, medical treatment, everything is covered, including the physiotherapy, occupational therapy, dietitian services, like if whatever is needed, the subspecialty services, everything is covered. When it comes to the ophthalmologist or optometrist services, they are covered for a certain pediatric age group, but otherwise for the adults, it is not covered. And the other major one for us is dental. Dental, again, limited coverage for the pediatric patients, but no coverage, dental coverage for adults.
Got it. Thank you. The social determinants of health have been spotlighted more recently in American publication literature, and understanding them is very important to becoming better clinicians. And so when we compare it to the universal Canadian healthcare system, Americans must have insurance or be eligible for Medicaid. What role do the social determinants of health play in the healthcare disparities that you've witnessed in your patient population in Ontario?
Minahil, if you can repeat your second half of the sentence, second half of your statement.
Right. My apologies. I was talking really
It's
fast. So a couple of social healthcare disparities include socioeconomic status, economic stability, education access, and healthcare access. And so when we're comparing that to universal Canadian healthcare and American healthcare, what role would social determinants of health play in the healthcare disparities that you may have witnessed in your patient population in Ontario?
Yeah. So again, good question. I think when we look at the medical model here in Ontario, it does not matter what socioeconomical status a family has. Their basic health is covered, right? When they come to the clinic, walk-in clinic, emergency department, they don't have to worry about it, that this visit, if it is going to be covered or if they have to pay out of pocket. So what I find here is that they seek medical attention sooner than later. They don't wait till things become worse. They come very early on, because I think it's more of a safety thing also. They know that they will be well taken care of. This is one of the important factors, I would say, that helps determine, rather than coming in with a very sick child, they come in very early on, because they don't have to worry about clinic visit pay or hospital pay, immunizations. The basic health of the patient is covered, right?
Thank you. I really appreciate it. And what would you say is the most pressing healthcare need that children are lacking in communities where healthier access and possibly resources may be limited, as you mentioned towards the beginning?
Yeah, exactly. So, I have to organize my thoughts. There are a few.
That's
There
okay.
always is, right? There always is. When you talk about the first tier medical management, it's very easy. You saw either the primary care physician or the consulting pediatrician. The first tier medical management is done and it's very smooth. When it comes to the second tier, and second tier I'm talking about now, the general pediatrician has done their assessment, and now we need to arrange for services in the community or get the referrals for the tertiary care hospital. That may have some challenges. For example, in Ontario, personally speaking, in Ontario, what I find is that arranging for dietitian in the community and all that is very easy. Easy means it gets arranged on a timely manner. If you have a fairly to thrive kid, you want a dietitian in the community, it is, I know that I don't have to worry about it. It will be arranged in an appropriate amount of time. But then, for example, when we have a kid with a developmental delay, you want to arrange for occupational therapy, for physiotherapy, like all those things. We have certain centers that offer those services that are OHIP covered, and it's very nice. They are OHIP covered. They don't have to pay out of pocket, because otherwise they're very expensive. They can be sometimes challenging because there is a huge waiting time. So there you can compare when you're paying out of pocket versus the government is covering. When the government is covering, there is a long waiting time, right? So they will get into the system once they get the spot, and that can delay their management. And then the other thing that I find can have delays is that when you are referring kids to the subspecialists in the academic center and they have long waiting time, that can be to the point that I, as a pediatrician in the community, may not think that it's appropriate to wait for that long. But then we have found solutions for that too. And we have now pediatrician subspecialists who are working in the community, trying to take the pressure off of the community centers, and they have their clinics in the community. And then now we have started to refer to them. But to summarize, as I said, first tier management, I don't think there is any delay. Second tier management can have some delays.
Got it. Thank you so much, Dr. Asim. That was a very detailed response. I really appreciate it. And my next question is, how do you manage children's patients, or children's parents, my apologies, children's parents, when they try to help with the exam and ask lots of questions?
Very good question. So yes, exactly. How do you manage? Honestly, what I find is you just have to get comfortable with that family and go with the flow. I always let the family take the lead. I explain them everything. And I tell them it's more of an opportunistic exam. I need parents' cooperation and parents' help for me to examine, especially certain areas. For example, that's the oropharyngeal exam, throat exam is almost like a nightmare when we have to examine that. So we need parents' help, right? And the ears, not that challenging though. There are certain things that you can examine right away. You don't need parents' help or anything. You just go over your, what are you going to do, and go over your findings. But for certain things that you need help with, they're always very, very helpful, because they always want to know what's going on with their kid, to find out about the assessment and the plan and all that, right? So certain times you get into situations when it can get very challenging, honestly. That's why developing the trust of the family right from the beginning, even if I'm looking at a kid with asthma, is very important, right? And developing that trust pays you off, always pays you off. I always tell the learners in the hospital also that never think that you're dealing with the child only. You're dealing with the whole family. And developing your rapport right from the beginning is extremely important. That literally helps you out throughout the process, always.
Thank you. And my next question is, as we know, many parents complain about teenagers' behavior during their adolescence. So at what point does it become problematic behavior for teenagers?
It's a very tricky question to answer. Teenagers. So as the physician, it's very important for us to know what is normal, when we should start getting concerned, and when we should say, you know what, this is an issue, and now we have to deal with it medically, right? We get these referrals or these consults all the time when parents are worried that they are actually concerned there is something wrong with the kid. And when you talk to the child, most of the times it's not. What I find is the most important thing is the family unit. The more kids, it's very easy for me to say, and I know practically speaking, it's very hard, but the more kids have bond with their parents, a trustworthy bond, the more they work together, the less are the issues. Having said that, my personal experience is that most of the times this is not the situation. Then it becomes very important that you develop a trusting relationship with the teenager. It comes down to this, and that once you have a trusting and a successful relationship with your patient, then you can guarantee you will have a positive outcome. And to develop that trust is not easy. And as I said earlier, it's a very tricky question to answer, because there are so many things depending on the age of the child as they grow older, that based on confidentiality, you cannot even share with the parents. So if the parents have come in with the issue and they want the answers, depending upon the age of the child, like for example, 17-year-old, I am not able to share every information, especially if the teenager does not want me to, right? So that I find is the most challenging piece here. I may be able to identify if there is an issue. I may not be able to tell the parents what is the issue and what are we working on, right? So teenagers are quite different than any other pediatric population we deal with.
Thank you so much, Dr. Asim. And for our last question, how do you manage your work-life balance?
You learn over time. You make mistakes and you learn over time, and yet you get mature. This is literally the human nature. But having said that, it's very important that you learn how to, it's a skill that we work on. And once we have brushed up on that skill, then we learn how to balance the life, the professional and the personal life. And it's extremely, extremely important for your own personal, mental, and physical health that you do that. Yes, we come in this profession because we like this profession, but it can be very, very high demanding, especially depending on what is your subspecialty or what area you work in. But at the same time, very important for us to learn the balance. So personally speaking, I make sure that I'm working certain weekends, but certain weekends I'm definitely off. Because I do more hospital work, it can be very, very exhausting and straining. So I definitely cannot work every day. So I make sure that I do certain days, my calls are spaced out. I have enough time to recover before I do another call. And I'm doing only certain number of weekends. I take some time off for vacation, to be with my family and to rejuvenate, right? You need all that. You need to spend some time on yourself also.
Thank you, Dr. Asim. We really appreciate you truly taking the time to answer all of our questions and coming to mentor us on a weekend and after your call. It was a greatly informative learning session for all of us, and I'd love everyone to please give a warm thank you to Dr. Asim, our TeleShadowing Medical Director, in the chat box for this incredibly informative session. Thank you.
Thank you so much for having me.
Of course, thank you. And if you'd like to learn more about our team, feel free to check out our website, where we have Dr. Asim's bio on there and also the rest of our medical directors.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live, and you'll need a 70% or higher to pass and receive certification. The link to the quiz is being sent in the chat now. Don't forget to also join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox, and you can join from the link that's being sent in the chat now. Now we're going to move on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And I'm looking forward to seeing all of you at our next session next Saturday on December 4th at 10 a.m. Eastern Standard Time with one of our medical directors mentoring us in internal medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.
Okay, thank you, everyone.